Welcome back to Do No Harm, where we fight for patients and against identity politics in healthcare. Podcast hosts Benita Cotton-Orr and Dr. Stanley Goldfarb will highlight the medical industry's most pressing issues and dangerous trends, and discuss how we can achieve a better healthcare system for all.
Welcome back to the Do No Harm podcast. My name is Benita Cotton-Orr, and I'm a senior fellow at Do No Harm. You can find out more about our organization at donoharmmedicine.org. Today I'm talking to Dr. Stanley Goldfarb, who is chairman of Do No Harm. Again, donoharmmedicine.org is where you can find out more. Stanley, it's great to see you, and thank you for being with us again. We're going to talk today about healthcare and the paths we can take in the future. So I know we have two paths that we need to consider. What are the most important things that we need to look at as we plow ahead to make sure that we have the best healthcare available for individuals?
Yeah, thank you, Benita. It's great to be here, be with you, and speak about these issues. You know, as we've said in previous sessions that we've had, the best way to improve health disparities, which are certainly real, the best way to improve them, in my view, and I think the literature does really support this, is to make sure that patients have access to health care. The problem is not racism in healthcare. The problem is not bias in healthcare that is the basis of disparities. The problem is more access in healthcare than anything else. Now, access in healthcare is complicated. There certainly are insurance issues that are a part of the issue, and the American healthcare system is a difficult system to navigate. So anything that can be done to improve access to healthcare by patients who have had poor outcomes is a system that ought to be implemented. There have been many examples of improving the outcomes for African American patients when interventions have been applied, such as nurses making home visits, telehealth, which has improved their ability to get to their appointments. At my institutions at Penn, for example, they found that follow-up visits after surgery were much less frequently attended by Black patients compared to white patients. I mean, they found that once they instituted telehealth, that the patients showed up for their appointments and were able to get input about their recovery from surgery. That sort of thing makes the difference. It wasn't that the physicians were biased against the patients. The patients weren't showing up for their visits, perhaps because of economic issues, perhaps because of transportation issues. So improving access is really the best way to do this. And I think one can show over and over again that if an intervention leads to improved access, it's going to lead to better outcomes. Now, one example that I think was disturbing was in North Carolina. The University of North Carolina had a program, one of the healthcare systems there had a program to improve the completion of chemotherapy by a group of patients. And they found that Black patients had a lower completion rate than white patients. And they decided to implement a plan that would get Black patients to have a higher rate of completion. And they did. They had a nurse intervention. Part of it was home chemotherapy. Part of it was simply helping the patients get to the treatments and the nurses intervening in this fashion. And they got the completion rate up from in the high 70% in Black patients up to the high 80% in white patients. So now they had equality. They had equal outcomes for both groups of patients. Well, that's fine, except they ought to improve outcomes for everyone. If an intervention is beneficial, then having white patients go up to 98% and getting Black patients up to 98%, that's the goal. Mm-hmm. The goal is not to have equal outcomes. The goal is to have optimum outcomes. And so if you're going to have interventions that improve healthcare, the interventions ought to be applied across all populations and to improve care. Now, if you need to have the interventions first in the Black patients, fine. That's understandable. There are limited resources. But that ought to be the goal. One should not be satisfied with an intervention that achieves still 10% of each group of patients were not completing their chemotherapy, and we're going to have a suboptimal outcome because of that.
I really like the way you said that the goal is to have optimal outcomes, not equal outcomes. That is so important. And when you look at the future of healthcare, we've been talking about patients. There's a really important aspect of this as far as physicians. When you're looking at equal representation of groups, proportional representation. So let's talk a little about the physician and the healthcare force itself.
Yes, and I think healthcare is different than some other fields. And the idea that merit is simply a social construct, which is what some individuals claim, that an individual who's achieved merit has not done so because of their own capabilities. They've done so because of certain social benefits that they've had along the way. And that may be true in many cases. However, healthcare is different than other circumstances, I think, because academics in healthcare actually is the way that healthcare is practiced. And what do I mean by that? I mean, I used to tell the students that for the first 2 years of medical school, we gave them multiple choice questions. In the multiple choice questions, we had a STEM, a little clinical vignette, and then they had to choose between one of 5 correct answers describing some aspect that we asked about, whether what's the right treatment, what's the right diagnosis, what's the right mechanism. I said to them, once they became practicing physicians, they write the multiple choice question about the patient in front of them. They create the STEM, and then they have to create the 4 or 5 possibilities in their minds as to what the right answer might be for that given patient. So the ability to succeed on multiple choice exams actually reflects the way one has to think in being a physician. And to say that physicians can get into medical school without having to show their ability to think in this fashion, to create these scenarios and to think of the multiple choices that occur. Yes, this is a kind of ability that you may be benefited by the way you were treated in your family, the kinds of schools you went to, the resources you had. That may be the case, but for optimum patient care, that's the way you need to be able to think. And if you can't think that way successfully, it's probably not the best field for you. So that's why this academic aspect of being a physician is really crucial. And individuals who are more successful in these academic pursuits are going to be more successful as physicians. So to have a circumstance like many schools have, where they're admitting students who are not able to be very effective on multiple choice exams and are substantially, sometimes a standard deviation or more below applicants that are of a different race, and yet accepting these students in and trying to carry them along through medical school who are struggling with these kinds of ways of thinking about the problems, I think is just creating a healthcare workforce that in some proportion of it will be less effective than it has been in the past. And that's my real concern. And if I could sort of expand it a little bit, my other concern is a sense that we should not identify the top performers in healthcare. And the top performers in medical school have been identified by an honor society called Alpha Omega Alpha, AOA. This was established in the beginning of the 20th century, 1915 or so. And it was specifically an honor society that was to recognize the top 10 or 15% of medical school classes, and specifically said that a student's gender, a student's race should not enter into the decision of whether they should be accepted into this honor society. 1915. And it was supposed to be a race-blind, total neutral, gender-blind, gender-neutral kind of acceptance. Well, here we fast forward to about the same point in the 21st century, and now this honor society has been first eliminated in a number of schools because it was felt that there weren't enough minority students who were being in the top 10 or 15% of their class. And instead, they decided in the schools that preserved the honor society, decided to use a holistic approach, taking into account community leadership and other activities as activists leadership activities that were going to count towards this honor society. So realize that an honor society that some patients actually use to identify the physicians they want to go to. Are they members of AOA? Some of the more really knowledgeable patients will look at that, whether they have that categorization in their little bio that they might have on the internet or a plaque that they might have on the wall of their office. That's not going to no longer represent the most outstanding academic physicians. That's going to represent physicians that they may be wonderful people. They may have done fine in medical school, but they didn't do as well as some other students in medical school, and yet they're being honored by this kind of organization. Or it's eliminated totally, so it no longer can serve to identify the highest performing students. I think this is a terrible mistake. We need to have a medical workforce that's at the highest intellectual activity that's possible, and one that's capable of carrying out this sort of intellectual activity. And it's the highest one possible. There may be gradations of capability of physicians, but we ought to have the most capable individuals be the ones who are given this opportunity to treat patients. And we have a system now that's undermining this kind of approach.
You talk in your book about some of the Black physicians who have excelled and based on merit and not any kind of preferential treatment. Would you care to expand on that a little?
Yes, in my book I talk about 4 physicians who, as just exemplars of this of incredible achievements, 25 to 40 years ago in healthcare, where they rose to the very highest rank of American physicians. One of the premier internists and most honored physicians at Penn, Dr. Ed Cooper, was the president of the American Heart Association about 35 years ago. And he was an African-American physician who was very important in doing work in stroke medicine and hypertension. And he rose to the very highest levels of that organization, again, well before there was any sense that there was such a thing as structural racism in healthcare, and that the need to purge healthcare of all implicit bias and allow leadership to be manifest amongst the Black community. Here was a Black physician who rose to the very top of the organization. Dr. Jerry Thompson became the first Black chairman of the American Board of Internal Medicine back again in about 35 years ago, well before there was this idea that organizations needed to elevate Black physicians into positions of leadership. There were Black physicians in positions of leadership who were there on the merit of their achievements, on their intellectual capacity, and on their leadership qualities. And finally, I think a name that many people know, Dr. Ben Carson, was one of the outstanding pediatric neurosurgeons in the world, did groundbreaking procedures in separating conjoined twins that he was very famous for in his medical world, and then became a celebrity after taking on President Obama at a prayer breakfast when he spoke out against his the ideas that there was the need for Obamacare at that time, and Dr. Carson felt very strongly about the need for individual kind of achievement in medicine, and subsequently became, a cabinet member in the head of housing and urban development. These are individuals who rose to the very top of their profession well before this idea that we needed to purge racism out of healthcare. And I think they illustrate the fact that healthcare has not been the source of racial bias in the United States, certainly over the last several decades. And again, we need to think about the future. We can't be thinking about 200, 300, 400 years ago and saying that these circumstances still exist. Certainly there's residue from those times, and that residue needs to be dealt with, but it needs to be dealt with by politicians. It needs to be dealt with by governments. It needs to be dealt with by legal systems. It can't be, and it doesn't need to be dealt with by the American healthcare system.
These kinds of organizations that elevated these excellent Black physicians, where are they now?
They're as woke as anything you can imagine.
Wow.
And again, I think the dynamic in those institutions of why they've become this way, I think is something that we spoke about in earlier podcasts. The genesis of this woke mentality through many fields is very complicated. I think part of the problem is they've all jumped on the bandwagon early. They've hired diversity staff. They then have the need to satisfy the diversity staff who are complaining when they're not demonstrating allegiance and fealty to woke ideas. And it's just easier for these organizations that have two aspects to their leadership. They have a permanent staff, and then they tend to have a staff, a group of leaders that are elected periodically to leadership in the organization who come from the academic ranks, who in their own home institutions have large diversity staffs that they have to satisfy as well. And certainly some of them may be true believers and think that this is the best approach that they can take. But I think many of them are more crafty than that and understand that this is a dynamic that it's easier for them to support than it is for them to oppose. It's easier for them to speak in a way that a Twitter mob is not going to come for them. And it's easier for them to support these ideas than to really point out the inherent flaws and the potential dangers associated with these ideas. So these organizations have adapted woke mentality, I think, in a fashion that just benefits them in a very cynical fashion for many of them. And again, I don't deny that these folks think that they're doing the right thing and that they're helping the community. But in fact, by eliminating the most scientific principles from the publications that many of these societies support, by eliminating the idea that merit underlies the way that leadership is chosen and that individuals have a chance to enter the healthcare world, and that merit is the basis for identifying the most talented individuals, that they're really doing harm. They're undermining the achievements that people like Dr. Thompson, Dr. Cooper, Dr. Carson had actually achieved by suggesting that the reason that they achieved these positions was because of their race and not because of their individual achievements, which I think is really unfortunate.
We'll be talking next in our next episode about how we stand up for what we believe in. So thanks, Stan.